Testing. Okay, so let's get started. Alright, so this is the second lecture in the nervous system unit overall. Today we're going to cover the central nervous system, the brain, and spinal cord. We're also going to cover the cranial nerves at the end. So the spinal cord is a cylinder of nervous tissue that arises from the brainstem at the foramen magnum of the skull. Remember, foramen magnum was Latin for big hole, and it's the passageway for the spinal cord out of the brain and into the vertebral canal. So you remember the vertebrae, they have these cylindrical bodies anteriorly, and then there's an arch that circles around the back, and then that creates a foramen or a large hole down the center of the vertebra. And together, when the vertebrae are stacked, this hole or foramen passes all the way down and becomes the vertebral canal, okay, through which the spinal cord passes. So there are a couple of enlargements that we should be aware of. There's a cervical enlargement in the cervical region. There's a lumbar enlargement in the lumbar region. The cervical enlargement is going to give rise to the nerve roots that become the brachial plexus, and that's a plexus of nerves that innervates the upper limbs. And then the lumbar enlargement is going to give rise to the lumbar plexus, which is going to innervate the lower limbs. All right. So, good. So the spinal cord passes through, um, this says as far as the inferior margin of the first lumbar vertebra, L1, but actually it passes down to about the level of, well, in this picture that's about L1, but uh, it passes down to about L4, really. And at L4, the spinal cord will actually terminate. And what we have is this structure known as the cauda equina, which is made up of many spinal nerves that continue down the vertebral canal from there. And we should have a better picture of that. All right, so uh, the vertebral column is divided into regions. You remember the cervical, thoracic, lumbar, and sacral regions. And the vertebrae are named for these regions. So you have the 7 cervical vertebrae, C1 through C7. Easiest bones to name are the vertebrae. Then the thoracic vertebrae, there are 12 of them, T1 through T12. The lumbar vertebrae, there are 5 of them, L1 through L5. And then lastly, you have, wait, the lumbar's down here, sorry. Then lastly, you have the sacral vertebrae, S1 through S5, and then coccygeal vertebrae, CO1 through CO4. Although the sacrum and the coccyx are frequently treated as if they were one bone because they're fused. That is, the 5 vertebrae of the sacrum are fused and the 4 vertebrae of the coccyx are fused. Now the spinal nerves are going to be the nerves exiting the spinal cord at these levels. And so they're also named for these regions. You have the cervical spinal nerves, thoracic spinal nerves, lumbar, sacral, and coccygeal spinal nerves. And the numbers are similar to the number of the vertebrae, but there are some differences. So there were 7 cervical vertebrae. There are 8 cervical nerve pairs. All right. Now we say nerve pairs. Remember, there's a left and a right. So technically there are 16 cervical nerves, right? But 8 cervical nerve pairs. All right. Now in the thoracic region, the number's the same. There were 12 thoracic vertebrae. There are 12 thoracic nerve pairs. And in the lumbar region, there were 5 lumbar vertebrae. There are 5 lumbar nerve pairs. In the sacral region, there are 5 sacral nerve pairs, 5 sacral vertebrae. Here's another exception. There were 4 coccygeal vertebrae, but there's only 1 coccygeal nerve pair. All right. So here we see a vertebra again. Here you have that cylindrical vertebral body anteriorly. Posteriorly, you have that vertebral arch. Okay. Many of the vertebrae will show spine. Well, all of them will show. Pretty much all of them will show spinous processes. Many of them will have transverse processes as well coming off. But uh, the key here is this vertebral arch, which creates a space in the center of the vertebra. This vertebral foramen allows for passageway of the spinal cord, and with the vertebrae all stacked together, these foramen together make a space called the vertebral canal through which the spinal cord passes. We say it passes, but I mean honestly, it's not going anywhere. It's stuck in place. All right, now over on the side, you have these transverse foramina, okay, which are where we're going to see the spinal nerves exiting the spinal cord or spinal column here. All right, these little structures here are the nerve roots, and then they will merge to form a spinal nerve that exits through the intervertebral foramina. All right. So yes, we mentioned the cervical enlargement and the lumbar enlargements. They give rise to the brachial and lumbar plexi, respectively, which are in turn going to innervate the upper limbs and the lower limbs, respectively. So we see the cervical enlargement runs from the level of C4 through T1, and the lumbar enlargement runs from T11 through L1. When the spinal cord ends, it ends in this cone-shaped structure called the conus medullaris. Okay, this cone-shaped structure called the conus medullaris. It's a little blurry, might be kind of hard to see. Let's see, you can see the sort of cone-shaped appearance in this image here. All right, that's the conus medullaris. And leaving the conus medullaris are all of these nerves, which form a structure called the cauda equina. Cauda equina, we should probably know. You remember caudal means referring to toward the tail, and then equina, uh, being so close to Churchill Downs here, you should know equine refers to horse. And so this name means horsetail. And unlike most anatomical structures where you've got to look at it and squint and believe with all your might, the cauda equina, at least in my opinion, really does look like a horse's tail. All right. All right, so spinal nerves L2 through S5 and actually CO1 are going to exit the medullary cone and form this structure known as the cauda equina. And this passes through the vertebral canal. Okay. Spinal cord terminates up here, but the nerves actually continue down through the vertebral canal. All right. And so right here this is vertebra L5, this is vertebra L4. When we do a lumbar puncture, we're going to do a lumbar puncture here between L4 and L5. And the reason for that is that the spinal cord is terminated up here and that we're in no danger of hitting the spinal cord. It is still a dangerous procedure because if you tap into these nerves, you can damage them and that can have serious consequences. Uh, but when you are inserting the needle, you are less likely to puncture these nerves than you would be the actual spinal cord. Less likely to cause permanent damage down here at the level of L4 and L5. You can also do a cervical puncture, but those are incredibly dangerous. In the cervical region, of course, you are looking at actual spinal cord here. And you could, if you pierced the spinal cord, potentially paralyze someone from the neck down. So only in certain extreme circumstances would you perform a cervical puncture. All right, so the spinal cord and the brain are enclosed in three fibrous connective tissue layers called the meninges, or meninx, singular, meninges, plural. And these membranes separate the soft tissue of the central nervous system from the bones of the of the vertebrae in the skull. And we can see those three layers over here. The layer closest to the nervous tissue, right up against it, is the pia mater. All right. The next superficial layer is the arachnoid mater, and the outermost layer is the dura mater. All right. Now the dura mater is tough. It, excuse me, is Latin for tough mother, and it can be an incredibly tough tissue. And the space between this sheath and the vertebral bones is called the epidural space, and it's occupied by blood vessels, adipose and tissue, and loose connective tissue. When you get an epidural injection, say during childbirth, it's being injected into this space. If we go back a little ways, we have a picture here. You can see within the vertebral foramen or within the vertebral canal, we have the spinal cord. We also have some blood vessels and adipose tissue here. All right, and so when we get an epidural injection, they are injecting into this space, the epidural space, called epidural because it's above the dura mater or outside the dura mater. Next up, we have the arachnoid mater, deep to the dura mater, and it's a layer of simple squamous epithelium. All right, now deep to the arachnoid mater is going to be a space called the subarachnoid space, and that's going to be filled with cerebrospinal fluid. And so when we do a lumbar puncture or a cervical puncture, we need to tap a needle into the subarachnoid space and collect cerebrospinal fluid. All right. Now, the reason that the arachnoid mater is called the arachnoid mater and the space below it is the subarachnoid space. It's because the subarachnoid space is filled with a series of fibers that sort of looks like a spider's web. Of course, you know that arachnid refers to spiders, and so this space uh, is filled with fibers that look kind of like a spider's web. Actually, arachnids are any of those bugs with 8 legs, including scorpions and whatnot, and ticks. But when we think of arachnids, we usually think of spiders. From the Greek mythology, Arachnia was turned into a spider. All right, so then we have the pia mater. This is the innermost layer, and it's a transparent membrane that closely follows the contours of the spinal cord. In fact, if you were to dissect the spinal cord, it would be difficult to spot the pia mater because it's directly up against the nervous tissue, and it's very thin. So, if you watch the dissection video that I've posted, and you're looking at the brain there, what you're actually seeing is the pia mater on the top of the brain. The arachnoid and dura mater of the meninges have been removed. What you are literally seeing there on top is the pia mater. All right. So beyond the medullary cone, we see the terminal filum arise within the lumbar cistern. At S2, this fuses with the dura mater to form a coccygeal ligament. All right, and then extensions of the pia mater called denticulate ligaments are going to extend through the arachnoid mater to the dura and anchor the cord here in the sacral region. All right. In the brain, actually, the dura mater is going to have 2 layers. One up against the brain here on top of the arachnoid, and there's going to be a second layer against the bone. All right, so here's a cross section of the spinal cord. You're going to notice 2 things right away. We have gray matter and white matter. All right. Now, white matter is white because fat is white, and there's going to be an abundance of myelin here in the white matter. Of course, myelin, is a fatty substance. It's composed of about 80% lipid, so it's going to be pretty fatty, and so it's white in appearance when you've got a lot of it. Gray matter is gray because it lacks myelin. There's little to no myelin in the gray matter. All right. So what does that mean? Where do we find myelin, right? And we find that surrounding the axons. Yeah, and so that should tell you that the white matter is where we're going to find axons, myelinated axons. The cell bodies or somas are not myelinated, and so we're going to find a lot of them in the gray matter. All right. All right. So the gray matter is also the site of neural integration, where basically we receive information and then we are going to pass that on to an interneuron that either stimulates a motor neuron directly or sends the information up to, through these tracks in the white matter, up to the brain to get a response. In the case of spinal nerves, spinal nerve reflexes, such as the patellar tendon reflex, where you hit the patellar ligament with that hammer and you get the knee jerk response. That's a spinal reflex that involves sensory. Well, you have sensors in the ligament that detect it's been stretched when the ligament gets hit with the hammer. That information is passed on to a sensory neuron, which is a unipolar neuron that carries it back here to the posterior root, and then the posterior root, posterior horn of the uh, spinal cord. And then here in this region, you would have the cell body of an interneuron, which is going to pass that information along. It integrates the information by receiving the stimulus and then deciding to stimulate a motor neuron whose soma or cell body would be down here, and then carry out the response through the efferent pathways on down to the effector, which in this case would be, the hamstring muscles to flex at the knee. All right, so gray and white matter. White matter is myelinated. You're going to find axons. And in this white matter, you're going to find a lot of axons traveling to different levels of the spinal cord. So they form what are called tracks, and those tracks can move up or down to different levels of the spinal cord. Many sensory tracks are going to travel up to the brain, and many motor tracks or efferent tracks are going to travel down to the effectors, to the level of the effectors. And remember, the effectors are glands or muscle. All right, so we see here more cross-sectional anatomy. This one's a little difficult to spot. We have 2 to 3 horns on each side, so you have dorsal horns in the gray matter. These are also known as posterior horns, and we actually do go back and forth between posterior and dorsal. Either one's fine. We use them interchangeably. You can use that however you like. All right, so then you have the ventral horns or anterior horns, okay, of the gray matter. And then at some levels of the spinal cord, you will have lateral horns. Not every level of the spinal cord, but some levels you will have lateral horns, okay. The two sides are connected by a structure called the gray commissure, and in the center of that is the central canal seen here. The central canal is a passageway for cerebrospinal fluid within the actual spinal cord. All right, and you can see it actually better on this slide. You've got the posterior or dorsal horns, anterior or ventral horns. All right, ventral horns. The ventral horns are going to be larger because this is where we have cell bodies for motor neurons. And then you have the gray commissure connecting them and the central canal in the middle. All right, let's see. Good, good, good. So there's a fissure and a sulcus that are worth noting. You have the ventral fissure in the front. This is like an infolding of the spinal cord. And then you have the posterior median sulcus, which is similar to the ventral fissure, but it's just more shallow. All right. And so this is a pretty good picture. Obviously, there's a gap in it, right? All right, so we have a sensory neuron coming in through the dorsal root. Okay, this is the dorsal root. And if you have to orient yourself here, remember the ventral horn of the gray matter is going to be larger than the dorsal horn. So you know this is the front, this is the back. We can go ahead and cite it that way. Back here, we have the roots. Okay, we have the roots, the ventral root and the dorsal root. And we have this sensory neuron carrying information in. We just talked about the knee-jerk reflex, the patellar ligament reflex. And so in that case, the sensory information is received first by the stretch receptors that are embedded in the tendon. And that information gets passed on to a sensory neuron that's going to carry it to the spinal cord. And so the axon of this neuron is quite long, leaves the spinal cord. Technically, it originates down in the tendon, travels from the tendon up through the knee, up through the femoral region, over to the spinal cord, and maybe integrated around the level of like L4, something like that. So that's a distance of over 2 feet in most people. All right, this neuron's going to be quite long. And it passes on to the posterior horn. Now, it's worth noting while we're here that the soma, or the cell body of this sensory neuron, is located in this swelling back here, this enlargement called the dorsal root ganglion. That's another thing you can use to identify the sides on an image like this. The dorsal root has a ganglion that contains the somas or cell bodies of sensory neurons. All right. The ventral root does not have a ganglion, right? Because the cell bodies for those motor neurons that pass through there are going to be over here in the ventral horn. All right. So there's no ganglion on the ventral root. All right. So this is sensory neuron, and then it's going to stimulate. You can see there's a gap here. There should be an interneuron in between. The sensory neurons are unipolar. You can see there's one process coming off here. And then the interneurons tend to be bipolar. All right, so they have one process coming off with dendrites up here. They have another process coming off with the axon and terminal enlargements, synaptic knobs down here. Now, when the sensory neuron carries the action potential back to the interneuron, which should be pictured here, it's going to create an excitatory postsynaptic potential on the dendrites of the interneuron, which, if it reaches threshold, will stimulate it to initiate an action potential that travels down its axon all the way down here, okay, to the motor neuron. Now, it also has synaptic knobs that are in contact with the dendrites of the motor neuron. And that's going to, again, create or result in excitatory postsynaptic potentials that increase the charge of the membrane here. And if we reach threshold, we will depolarize the motor neuron, and that action potential that's initiated will be carried down the axon of this multipolar neuron, okay, through the ventral root and then out through the spinal nerve, and then out of the spinal cord all the way down through the femoral region to the quadriceps muscles, to the effector, which in this case is actually not the quadriceps muscles. This would be the hamstrings. Sorry. And that'll cause contraction of the hamstrings that the withdraws the leg so that we can protect the tendon. All right. So in this example, we showed 3 different types of neurons. You have the unipolar neurons, which are sensory. you have the bipolar neurons, which are interneurons that connect the sensory and the motor neurons. And then you have the motor neurons, which are multipolar. Okay. Good, 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 good. One more thing to remember, I know we've said it, but the posterior horn is smaller than the ventral horn because the somas of the sensory neurons is out here in the dorsal root ganglion. There are a few interneurons, and their somas would be in here in the posterior root. The ventral root has somas for the motor neurons, and so that's why it's enlarged. That's why it's big. Good, good, good. So we mentioned the gray matter there. The white matter consists of bundles of tracks. The white matter, of course, is where we're going to find most of the axons in the spinal cord. And these axons are myelinated, which is a fatty substance, which gives the white matter its white appearance. All right, now these tracks, consisting of bundles of axons, are going to travel up and down the spinal cord to communicate with different levels in the central nervous system. And the bundles are arranged in three large pairs called funiculi. There's a posterior column, a lateral column, and an anterior or ventral column. And each column consists of subdivisions called tracts or fasciculi. All right, so you can see the funiculi are the large groupings, the posterior, the lateral, and the anterior funiculi. The fasciculi are the smaller divisions within the funiculi, and I won't expect you to memorize this image, but it is worth noting, just while we're here, the fact that there are several different tracts or fasciculi, okay? And then each of them is headed to a different region. And you can see in blue we have the sensory or ascending afferent pathways. And then in red we have the descending efferent motor pathways. All right. And so these tracks, not only are they heading to different regions, different levels of the CNS, some are heading up, some are heading down. It's also just worth thinking about as well that sensory input, if it's traveling to a different level of the spinal cord or to the brain, is going to be traveling up, right? Traveling up toward the brain. The motor output frequently comes from the brain, and so it has to travel down or descend the spinal cord. Yeah, so as we said, ascending tracks usually carry sensory information. It's ascending because it's heading up to the brain. Descending tracks carry motor impulses down from the brain. Now, several of these tracks undergo what's called decussation as they pass up and down the brainstem and spinal cord, and what that means is that they cross over from the left side to the right and from the right side to the left. Of course, you've probably heard at some point that the right side of your brain controls the left side of your body, right? And so if you are right-handed, then you are left brain dominant, they say. Um, all right. So you've probably heard that already, and it's true. Most of the tracks undergo decussation, which is that process of crossing over from the right side to the left side and vice versa. Tracks that are contralateral have an origin that's on one side and a destination on the opposite side. So basically, the tracks that do cross over are contralateral. Contra means against or opposite. Lateral, of course, refers to the side, so contralateral means opposite sides. Ipsi means the same, and so ipsilateral means the same side. Some of the tracks do not decussate, some of them do not cross over, and tracks that do not cross over are called ipsilateral. All right, so you can see a neuron here runs from the cerebral cortex on the individual's right side down through the midbrain, pons, the caudal medulla, and then in the spinal cord here crosses over or decussates to the left side, then leaves the spinal cord, travels down to a muscle fiber. And so this particular neuron, well, Okay, so there are two neurons here. We are stimulating a separate motor neuron, but the track crossed over. Okay. This particular pathway from the right side of the cerebral cortex here down to through the left side of the spinal cord and then out to a muscle on the left side of the body did decussate. All right, so you can see decussation here as well. We have the pons and the medulla oblongata, and this is where a lot of the pathways are going to cross over or decussate. So we've already talked about organization of the nerve in the last lecture. Um, there's no need to reemphasize that. All right, so we have sensory fibers, which are also known as afferent fibers, and motor fibers, which are also known as efferent fibers. Technically, the pronunciation of those words should be afferent and efferent, but that's so close together, I like to emphasize afferent and efferent so that you can remember how to spell them. All right, and afferent, this word comes up a lot in different parts of the body. It'll come up a couple times in A and P too, so we'll efferent. And they refer to input and output, basically. Afferent fibers carry input, sensory information. Efferent fibers carry output, motor signals. Okay, a motor response. You'll see that in, for instance, the kidney. In the glomerulus of the kidney, there are blood vessels coming in. Those are the afferent vessels in the kidney. And then capillaries, well, arterioles actually, leaving the kidney, and those are going to be efferent arterioles. So you'll see these words come up again a couple times in A and P2. Afferent refers to the input, efferent refers to the output. All right, and good. So we've talked about this. You can have nerves that only carry sensory information. You can also have nerves that only carry motor information or motor fibers, but this is actually somewhat rare. Most nerves are going to be what are called mixed nerves, meaning they contain both sensory fibers and motor fibers. All right. So a lot of textbooks say that a nerve resembles a thread and that a ganglion resembles a knot in the thread. I'm not a big fan of that description. I don't think it really looks like a knot, but if you picture that, you could see that a knot would be an enlargement along the string, and so in that sense, a ganglion is like that. The ganglion is an enlargement of the nerve, and that's where we find neurosomas outside of the central nervous system. The neurosomas for almost all of the neurons located outside the central nervous system are going to be in ganglia. So we mentioned also the nerve exits the vertebral canal through the intervertebral foramen or foramina plural. We mentioned the spinal nerves already. We didn't mention that there are 31 pairs, but if you'd added up those numbers, you would come to 31. And over here we have the spinal cord. Then you have the dorsal root and the ventral root. You can see in blue we have sensory fibers running through. They actually run in to the spinal cord. And then exiting the spinal cord we have the red motor fibers. And you can see that the dorsal root here, this region, the dorsal root, contains only sensory fibers. The ventral root only contains motor fibers. But then once we get out here, the two roots merge to form a spinal nerve, and the spinal nerve is going to be mixed. So it'll carry both sensory and motor fibers. Now, where this nerve diverges, there's going to be a dorsal ramus and a ventral ramus. The dorsal ramus may go on to innervate like the muscles of the back, something like that. The ventral ramus will travel out to maybe some organs or something like that. All right. So we have the nerve plexuses or plexi. Plexi is probably more correct. Anyway, so the cervical plexus is located in the neck. Seen here, the brachial plexus. Down here, the brachial plexus is going to innervate the upper limbs. Then you can see we've got the lumbar plexus and the sacral plexus. And sometimes these two plexi are treated as if they are the same. And so that we'll refer to it then as the lumbosacral plexus. They're not the same, but referred to as if they were one unit, called the lumbosacral plexus. All right, so somatosensory signals. Remember, the somatic nervous system detects stimuli that we are aware of, things like touch, heat, cold, stretch, pressure, pain, and that's all detected by specialized receptors for those things, many of them located in the skin, although some are located in muscle and bone and joints as well. All right. Proprioception is a sense we haven't talked about. Proprioception is your sense of the body's position and balance, and it's used to determine coordinate your body's movements. All right. So we have proprioceptors embedded in, for instance, muscle and tendons, and that tells us about the body's position. And so I can close my eyes and I can move my arms around, move my hands around, move my feet around, and I know exactly where my foot is because of proprioceptors. They detect the level of stretch in the joints, the ligaments, and also in the muscle, and that feedback, that sensory information gets sent to my brain, and my brain therefore knows the exact position of my body. And that's important because you need to know essentially what angle your joint is at, or the location of your foot before you can send information to that foot that would be useful in helping you stand up, right? Before you can send information to the muscles of the legs that would be useful in helping you stand up, you need to know what position your body's already in. There is a condition. It's very rare, and I'm not sure if it has a name, but where people lose proprioception. I was listening to an interesting case on the radio one day of a guy who just woke up and he couldn't feel the position that his body was in, and it's something that we all take for granted. But uh, for the rest of his life, because he couldn't detect where his body was, he had to look down at his body to see where his legs are so that he could know where to put his feet, right? Like how to contract the muscles in his legs to move his feet. He had to learn to walk visually. He has to look down at his legs and at his body to determine how he needs to move. He can't just feel it the way we do. He's totally able to walk. He just can't detect what position his body ends in. And that sense is proprioception, just to get back to the topic at hand. All right. So, there's a disease you've heard of, I'm sure, called chickenpox caused by the varicella virus, varicella zoster virus. Um, so it's a common disease early in childhood, caused by the varicella virus. Results in itchy pox. So the virus remains with you for life, and it lives in the posterior root ganglia, which we just saw. The immune system, if it is compromised, if the immune system is compromised, that is, the virus can travel along the sensory nerve fibers through fast axonal transport and cause shingles, which is also known as herpes zoster. That's characterized by a painful trail of discoloration and fluid-filled vesicles that travel along the path of the affected nerve. Post-herpetic neuralgia, neuralgia is pain. This is a chronic intense pain at the site of the lesions that can last for months or even years. There is a vaccine for the varicella zoster virus available to children, called Zostavax. Adults can get it up to over age 60. There's an age requirement actually uh, for children as well. And I always mean to look this up, so why don't we go ahead and do that? Vaccine chickenpox. Well, it's given when kids are between 12 and 15 months of age. Okay, you get a booster at 4 to 6 years of age. Kids who are older than 6 but younger than 13 can get the vaccine. All right. So I actually got chicken pox, and I think I'm in the last generation of people who naturally got chicken pox. I hear stories from the 50s. They used to have chicken pox parties. It was thought that if you got chicken pox as a child, then you couldn't get shingles as an adult, and that is very wrong. They would, but if somebody in the neighborhood got chicken pox, the parents would send their kids over to play with that kid so they could get the disease early and then hopefully develop an immunity that would prevent shingles later. It's crazy what we used to do. Um, Now there's a vaccine though, so get your kids vaccinated. Treatment for shingles is aspirin and steroidal ointments that will reduce um, swelling and cause pain relief. You can also administer acyclovir, which is an antiviral drug, but it's only effective if taken within the first 2 to 3 days of an outbreak. Acyclovir can be used to treat a number of viral infections, not all viral infections, but a number of them. It's used to treat, gosh, let's see, herpes and a few others. Um, Chickenpox is actually the virus, the varicella zoster virus, is actually related to the herpes virus. Um, but anyway, acyclovir can be used to treat all of these, but only if taken within the first 2 to 3 days of the outbreak. And unfortunately, you frequently won't know that the outbreak has begun until uh, after 2 to 3 days. After 2 to 3 days, it's worthless. Now, aspirin is for adults. Kids cannot take aspirin. It causes Rye syndrome, which is a weird neurological syndrome. I'm not sure how aspirin causes it, but it apparently does. And one of the weird side effects for Rye syndrome is nightmares. If you can imagine a disease that causes nightmares, how strange is that? It causes a number of other neurological defects as well, not just nightmares. That was just the most interesting one that stood out to me. All right, so on the left, we can see a child with chicken pox is infected. The pox are covering the body. The virus travels up the sensory fibers to the dorsal root ganglion, where it lives for the rest of your life, and then can spread out along the path of the affected nerve. And you'll see, yes, it follows the nerve, it follows the path, and you'll see these uh, sores developing along the path of that nerve. And so here is chickenpox in the kid, indiscriminate, covers the body. Now, as an adult, it lives in your dorsal root ganglion, and when you get shingles, it travels out along the nerve that is affected. All right, and follows this path. You can see the path of the nerve here. All right, so this map is called a dermatome map. A dermatome is a region of skin that is innervated by a single spinal nerve pair. And we can use this map to actually determine nerve function, which is pretty cool. So you can see this region in the upper chest is innervated by spinal nerve C4. Of course, this region is going to be innervated by the left C4 spinal nerve, this region by the right spinal nerve C4. Right. So we can follow this map, and if you want to determine nerve function, right, you can actually test for sensations in these regions of the skin. And if a person has no sensation and these skins can't detect pain, pressure, hot, cold, etc., there may be damage to the spinal nerve, which is supposed to innervate this region of the skin. All right, and so if you, for instance, could detect no, okay. If you could detect no sensation in L4, there may be damage to, I'm sorry, this region. I'm just thinking about myself all of a sudden. I've noticed strangely my left knee, the skin is numb, like I can't feel it. I'm wondering, I had a fall a couple weeks ago that initiated this sciatic pain. Just wondering if maybe the fall actually did have something to do with it and there might be damage to L4. Anyway, that's me. Here in the left knee, if you could not detect uh, sensations in the skin, you may be experiencing damage to the spinal nerve pair L4. Specifically the left, since we can look at the left leg here. All right, and we can use this map to ascertain nerve function. All right. The map's just one of those things that you'll probably need to refer back to if you ever need to use that information. All right. So the cervical plexus, we're onto the plexi now. They receive fibers from the anterior rami of the nerves C1 to C5, and they give rise to some special nerves: the lesser occipital nerve, the greater auricular nerve, the transverse cervical nerve, the ansa cervicalis, the supraclavicular nerve, and then the phrenic nerve. And the phrenic nerve is an incredibly important one. If you look here, the phrenic nerve travels down, there's a left and a right, and it innervates the diaphragm. If you sever the phrenic nerve, you are in serious trouble. Because you'll talk about this in the respiratory unit, but the primary muscle for respiration is the diaphragm. As I'm sitting here breathing, talking passively, not forcing myself to inspire or expire, just normally sitting here relaxed, the diaphragm is driving almost 100% of that respiration. We do recruit a few other muscles to aid in inspiration. We talked about the scalenes and the pectoralis minor muscles, which are going to lift the rib cage up. You also have the external intercostals, which are going to help the muscles between the ribs, the external layer. They're going to help. But the prime mover for respiration is the diaphragm. So you are in trouble if you sever this phrenic nerve. That's an important one. The brachial plexus is formed predominantly by the anterior rami of nerves C5 to T1. All right, and it passes over the first rib in the axilla and innervates the upper limb, as well as some muscles of the neck and shoulder. The cervical plexus, by the way, is going to innervate a lot of the muscles, for instance, of the neck. All right, so the subdivisions of this plexus are called roots, trunks, divisions, and cords, and you can see that here. We have the nerve roots leading to the trunks, and then divisions where we have some crossover between the nerves. Then finally we have the cords, and then lastly branches, which are going to lead to the main brachial nerves. You have the radial, median, and ulnar nerves. And remember, the ulnar nerve's the one you hit with the funny bone injury. All right. All right, so you can see that here. You have the roots coming away from the spinal cord, leading to trunks. Then we have some crossover in the divisions, and then we merge again to form the large cords that will ultimately branch off and become the specialized nerves, the median, ulnar, and then we have the radial nerve as well over here in the posterior cord. All right. You can also see that the nerve fibers that innervate these nerves are coming from the level of C5, C6, C7, C8, and T1, and that they don't necessarily stay at that level. So nerve fibers at C8, you can, if you follow here, can cross down to the medial cord, which largely comes from T1, but can also travel on to the posterior cord. We can cross over, we can change levels outside of the spinal cord. All right, then leading on, you can see the location of the median nerve. It's in the middle of the arm. The radial nerve is on the radial side. The ulnar nerve is on the ulnar side. And then we also have here the musculocutaneous nerve, which is going to innervate the muscles and the skin. The lumbar plexus is formed from the anterior rami. That's the plural of ramus, for nerves L1 to L4, and some of the fibers from T12 as well. And it gives rise to a couple important nerves. You have the iliohypogastric nerve, ilioinguinal nerve, the genitofemoral nerve, the lateral femoral cutaneous nerve, and then we have the femoral nerve and the obturator nerve. All right. All right. Now the femoral nerve is going to give rise to a lot of the nerves innervating the muscles of the leg. Then you have the sacral plexus, which is formed from the anterior rami of nerves L4, L5, S1 through S4. And it's connected to the lumbar plexus by fibers that run through the lumbosacral trunk. The two plexuses are, as we said, sometimes referred to collectively as the lumbosacral plexus. Then the tibial and common fibular nerves travel together through a connective tissue sheath that are collectively, when they're together, they're collectively called the sciatic nerve. At the popliteal fossa, which is behind the knee, they're going to split into the tibial and common fibular nerves. And then the tibial nerve descends through the leg, leads to the medial and plantar nerves of the foot. The common fibular nerve divides into the deep and superficial fibular nerves. Lastly, we have the coccygeal plexus, which is formed from the anterior rami of S4 and S5. So here you can see the sciatic nerve, okay, which is traveling through the greater sciatic notch, out and down, travels down the back of the femoral region. And then in the popliteal region, which is the region behind the knee, it diverges into the common fibular nerve on the fibular side. And on the tibia side, it becomes the tibial nerve that travels down and into the foot. Okay. Now, the sciatic nerve is actually composed of the common fibular nerve and the tibial nerve. They are together wrapped up in a connective tissue sheath. They're actually separate nerves that have been wrapped up together. And when they are wrapped up together for this region through the back of the femoral region, they are together called the sciatic nerve. All right, so that was the spinal cord and the spinal nerves. Next, we're going to talk about the brain and the cranial nerves. All right, just one second. All right, so the cerebrum, we're going to start here. It's the largest portion of the brain, and it constitutes about 83% of the brain's mass. Of course, we see the cerebrum up here. All right. And it's composed of thick folds called gyri and these depressions called sulci. Sulci is plural, sulcus is singular, gyri is plural, gyrus is singular. All right, and so there's a deep median groove called the longitudinal fissure that separates the left hemisphere of the cerebrum from the right hemisphere of the cerebrum. The cerebrum, by the way, is divided into hemispheres or half spheres, and they are separated from one another by this longitudinal fissure. At the bottom of the fissure, the hemispheres are connected by a thick bundle of nerve fibers, seen here, called the corpus callosum. It's a bridge of white matter that connects the left and right hemispheres. Here you can see the gyri. The gyri are convex and the sulci are concave. Okay, basically the gyri stick out, the sulci are depressions. Okay. Gyrus singular, sulcus singular. All right, and then here in the brain you can see the longitudinal fissure, which is this deep depression that separates the left hemisphere from the right hemisphere. And I tried to show it in the dissection video, but if you were to hold the two hemispheres and pull them apart, you could peek down in and see the corpus callosum. Now, the corpus callosum is actually a very delicate structure, and I'm not sure if we were able to see that in the dissection video. I don't remember. It's pretty common to wind up tearing it accidentally. That happens. All right. So the cerebrum is divided into five lobes, and these are going to be pretty easy to remember too. The frontal lobe is behind the frontal bone. It's also in the front. The parietal lobe is under the parietal bones. The occipital lobe is anterior to the occipital bone. It's under the occipital bone, or in front of and actually technically on top of. The temporal lobe is next to the temporal bone. And then there's a fifth lobe that we actually can't see here called the insula, and you can only see it if you cut away um, the temporal lobe and look inside. But so the fifth lobe is the insula. All right, now the frontal lobe, this is commonly referred to as like the executive wing of the executive branch of the brain. This is where we store our personality, some of our memories. When we make decisions, we do that with the frontal lobe. When we try to see the future, or well, not literally see the future, but when we make predictions, we're making that with the frontal lobe. All of our personality really is stored in the frontal lobe. If you've ever taken a psychology course, they always talk about the case of Phineas Gage, who was a railroad worker through an accident while working on the railroads, or rather, he was working on the tracks. There was an explosion that sent a spike through the frontal lobe of his brain, and everyone thought he would die, and then he didn't, because you don't actually need the frontal lobe to live. Um, Most of what we consider, what it means to be human is performed by the frontal lobe. But so it passed through, and then we saw with him a number of personality changes. He would run around naked and scream at people and, frighten children and things like that. And before that, he had apparently been just a super nice guy. Uh, Kind of a strange story about Phineas Gage. He disappears for a while and then shows up shortly before his death. All right, so the moral of that story is that basically your personality and behavior and all these things are dictated by the frontal lobe, and he suffered damage to his frontal lobe, which was not fatal because the frontal lobe doesn't do anything to keep you alive, except maybe help make you make good decisions. Um, but his personality was stored here, and it was uh, distorted after the accident. All right, back here, separating the frontal lobe from the parietal lobe, by the way, is the central sulcus. That's another important structure. The central sulcus divides and separates the frontal lobe from the parietal lobe. Parietal lobe is responsible for receiving sensory signals and interpreting them. In fact, the primary somatosensory cortex is located in this ridge here, just behind the central sulcus. Okay, so when you detect information in the skin, muscle, joints, bones, etc., that is carried back here to the primary somatosensory cortex, this ridge behind the central sulcus. All right, so if someone pinches you, you feel it, you interpret that information right here, somewhere in the central sulcus. And if they're pinching your arm, it'd be roughly this region. Not 100% sure. There is a diagram that shows us that. I think we've got that a little bit later in the lecture. Then the occipital lobe is the primary visual center of the brain where we interpret visual information. And people have known for a long time that if you hit the back of your head hard enough, you'll go blind. And that's because the occipital lobe back here interprets visual information. The temporal lobe is responsible for things like hearing, smell, but also learning and memory, and it is responsible for some aspects of vision and emotion. And then lastly, the insula is that lobe that we can't see deep to the temporal lobe. You have to cut away the temporal lobe to see in and get it. Here we have one more time the longitudinal fissure separating the left and right hemispheres of the brain. Here we have the central fissure or central sulcus separating the frontal and parietal lobes. You can see that here as well, central fissure separating the frontal and parietal lobes. Now, right here we have the precentral gyrus. Pre because it's before, right? If you go from front to back, before the central fissure is a precentral gyrus. Now, after the central fissure is a post-central gyrus. All right. Now, we've already said that the post-central gyrus, which we see here, is the primary somatosensory center for the brain. This is the part of the cerebrum that's going to receive and interpret sensory information, somatic sensory information, the things that we're aware of. Anterior to that is the precentral gyrus, and this is the primary motor cortex. Okay, and so this gyrus is going to be responsible for initiating body movements. All right, now we initiate the body movements here in the precentral gyrus, and then the cerebellum, seen down here, is going to be responsible for coordinating those body movements. And so I can say, jump up on one leg real quick. The cerebellum looks at the position the body's already in, feedback it's getting from the proprioceptors, and looks at movements that you've made recently, and then adjust them, adjust the input it's getting from the precentral gyrus. All right, before sending it out to the motor pathways. All right, so primary motor cortex is the precentral gyrus. Postcentral gyrus is the primary somatosensory cortex. All right, so the cerebellum, we just described a little bit of its function. Its main job is for maintaining balance, body posture, body position, things like that. It also receives information from the primary motor cortex, as we said, and it also receives information from the body about body position, and it's going to adjust or alter the motor commands to help keep us from falling over. So the cerebellum, it sits in the posterior cranial fossa on the floor of the cranium, and it consists of cerebellar hemispheres. There's a left and right cerebellar hemisphere connected by a thin ridge called the vermis. And instead of gyri, it has these small folds called folia, but we still see sulci in between. All right. Now, most of the fibers here are going to be known as Purkinje fibers, or some people pronounce that Purkinje. A lot of people pronounce it Purkinje fibers located in the cerebellum. All right, so the cerebellum has three peduncles, which are essentially connections between the cerebellum and the brainstem. So the inferior peduncles, seen down here, are going to connect the medulla oblongata to the cerebellum, and of course the medulla oblongata is seen here, so you could probably guess that. The middle peduncles are going to connect the pons, this structure, to the cerebellum, and then the superior peduncles are going to connect the midbrain to the